Thank you very much, Maggie, for those kind words. And I want to sort of kick off just by setting the scene for the work that we did in the region by describing some of the national context which helped us. So if we can go on to the next slide. Thank you. If you cast your mind back quite a few years now to when the 5-year forward view came out, it's had a priority around improving CVD prevention. And Public Health England at that time set up a CVD prevention project with national and regional colleagues to take this ambition forward. And certainly regionally, one of our key objectives was to ensure that by supporting and influencing, the STPs had a formal commitment in their plans to take action on at least one of the high-risk conditions for CVD. So that's AF, blood pressure and cholesterol. So that was the ambition that we were working on. If we go on to the next slide. Thank you. So at the same time, PHE set up the CVD Prevention System Leadership Forum, which had a name that was rather too long, and a very wide membership of passionate colleagues from the NHS, from local government and the charities, all committed to reducing CVD. And one of the bits of work that we did through that group was to set some ambitions for England for reducing CVD. So ambitions for diagnosing the underlying risk factors and treating them as well. And certainly in the South East, we found this really helpful as a means of benchmarking where local systems and CCGs and practices were in achieving those ambitions. And if we go on to my last slide, at the same time, so the Centre Directors in PHE were working closely with the Association of Directors of Public Health on a programme called What Good Looks Like. And this is really about describing, as it says, what good looks like at a system or a place level, as we might say now, for a whole range of different public health issues. And one of them was CVD prevention. So if you haven't already looked at this publication, this is on the ADPH website, easily found through Google. And what it does, it describes some of the key features and principles for what good would look like at a local level. And it was really interesting, particularly hearing Chris's presentation, because I think we're talking about the same things. The leadership is really important, and having that compelling narrative to get this issue onto the agenda, the use of population intelligence. The other thing for me, I think, is that having a systematic approach to a population-based approach, really key. We recognised when we did the work that this is a really big challenge, and we're going to have new models of care, new pathways to help detect and manage people with these risk factors. The other key thing is about the quality improvement element of that programme. These things don't just happen, you have to iterate, look at how well it's going and develop your approach. And the other really important bit of this is, the blood pressure management and detection is really important, but the understanding this is in a wider context of health and well-being and health in all policies within local government. So the document covers everything through from detection to those wider issues. And I think, we've probably all started to hear about the new NHS initiative on Core 20+5, which will target the two most deprived deciles. And one of the issues that will be targeted is blood pressure detection. So I think this document will be helpful in colleagues locally in thinking through some of the approaches that they might take. So that's just a bit of scene setting of some of the things that helped us in the South East as we were taking our project forward over the last few years. And Saloni is going to talk now about what we actually did and achieved.
Thank you, Alison. My name is Saloni Zaveri. I'm one of PHE South East's healthcare public health consultants. And one of my roles is to work as part of a team in PHE South East and in collaboration with partners to deliver against our CVD prevention work programme. So I'm just going to spend the next 15 minutes or so talking through how we in PHE South East worked collaboratively with our partners and with systems to deliver the national CVD prevention programme that Alison has just described, and how our approach has evolved over time. So just some scene setting first around CVD in the South East. This data was generated using the GBD compare tool, which John has already described, and this uses estimates from the GBD study. And we can see from this chart that whilst there have been improvements in the treatment of CVD over previous years, it still remains the second largest cause of DALYs in the southeast, and it accounts for just over 14% of all DALYs in the southeast. Next slide, please, Julian. Thank you. So this scarf chart shows for each cause of death the percentage contribution that it makes to the overall life expectancy gap in the southeast. And here we can see that the life expectancy gap between the most and least deprived quintile in the southeast is 6.7 years for males and 4.8 years for females. And we can also see that circulatory disease is the largest contributor to this gap for both males and females, accounting for over a quarter of inequalities. Next slide, please. So within the CVD high-risk conditions, we have already heard that hypertension is the largest attributable risk factor for CVD DALYs, accounting for 43.1% of total CVD DALYs in the southeast. So these three slides that I've just shown, amongst others, feature in the PHE CVD data packs that I'm going to describe shortly. Next slide, please. CVD has been a key priority for PHE since 2018, when the national programme was launched. In 2018, dedicated resource was allocated to regions across England to support the implementation of this national project. And regions used that resource in different ways, but in the southeast region, we appointed a CVD prevention programme manager who was in post for just over a year until midway through 2019. When we were starting out, I think it's fair to say there'd been a shift in focus to diabetes rather than CVD more broadly as a clinical priority area for the NHS. So we identified a gap here and an opportunity to set up a southeast-wide group with all relevant partners involved in CVD and CVD prevention across the southeast. And this is not an exhaustive list, but it included NHS England, an improvement, NHS Right Care, the British Heart Foundation, amongst other voluntary sector organisations, NICE, the academic health science networks, and we were brought together regularly to focus on CVD more broadly. And just thinking about ambitions, Alison has talked about the development of the national ambitions, and Alison and other colleagues in the southeast were very much actively involved in and supported the development of those ambitions, which were then adopted nationally and then later on integrated into the NHS long-term plan. Very early on, there was clear recognition in the southeast, as elsewhere, of the importance of using data and supporting systems to use data and intelligence effectively to tell the CVD story through effective narrative, so that we really could engage our partners. So from this, the data packs that I'll talk through in a moment were born in the southeast, and they then became national products. So in summary, the PHE Southeast offer was to act as the system leader for CVD prevention at that time across the southeast, influencing and supporting local stakeholders to deliver improvements in CVD. Next slide, please. So the agenda was vast, and we started out by organising our thoughts systematically to set out very clearly where we thought we could intervene and what impact we could have with respect to health and social care outcomes. And this is our Southeast PHE CVD prevention logic model. It's essentially a roadmap showing the key aspects of the programme and its interventions and how they will bring about the desired outcomes. Next slide, please. So for the next few minutes, I'm going to talk about our approach to implementing the programme through making the case locally to systems for the programme, using the best available data and intelligence, working with local systems to commit to ambitions for improved outcomes and to develop more effective models of working, and through deploying our CVD prevention programme manager, who really enabled us to offer much more operational support for the planning and coordination of CVD secondary prevention activities at system and regional level than had previously been possible. Next slide, please. Thank you. So as I've mentioned, very early on, there was clear recognition of the importance of using data effectively and developing the narrative to engage partners and inform action. Most CVD risk factor identification and management happens in primary care, I think it's fair to say. And here in primary care, identifying and treating people with AF, hypertension and high cholesterol optimally is absolutely crucial. Within these data packs, we have looked at CVD management as a whole pathway approach. And CVD prevention starts to the left of this pathway with primary prevention. So healthy eating, physical activity, not smoking, moderating alcohol consumption. We know all of these things can reduce your risk and stop you from even entering the CVD management pathway. So our data packs contain a comprehensive set of data on risk factors, on NHS health checks, hypertension and AF management and diagnosis, and alongside gaps to ambitions for our local systems. Now, data is displayed in the packs at CCG and GP level, and now, since the packs are evolving, at PCN level. And the data comes from a range of sources, such as fingertips, the QOF, PHE, disease prevalence models. All of these are in the public domain, but I should say that the analyses and the methodologies used to generate the figures in the packs are underpinned by the national CVD prevention ambitions, which means that they might differ somewhat from other published figures. So now these packs are in their fourth iteration. The latest packs, as I've said, include data presented at PCN level. The narrative has continued to evolve, and these packs really still remain a critical tool which we use to interact with our systems. They really, the data in these packs enables systems to identify where their gaps are, what their priorities should be, and where focus is needed at place level. And now a number of systems have used these packs to support bid development. For example, the recent digital weight management program, Expressions of Interest, and to support their decisions around distribution of resources. Next slide, please. So I mentioned also that we identified early the need to bring key strategic partners together to coordinate CVD prevention activities, notably secondary prevention. And the opportunity was taken back in 2018 to establish the South East CVD Prevention Group. Some of the members are shown here, and I've listed them previously. They're not exhaustive. They did also include system representatives later on. So the group is hosted by Public Health England South East and still continues to meet to provide South East system level support and leadership to groups working on CVD prevention. And I should say this is complementary to the support to local systems that local authority public health teams provide. And this group really still continues to be a valued forum which meets bi-monthly. Examples of good practice, challenges and learning are shared between members. We support the planning, mobilisation of resources and implementation of interventions in local systems, and really foster closer working with local CVD prevention leadership. Next slide, please. So this is our plan on a page which attempts to summarise some of the detail I've talked to and much, much more. I think importantly, the South East CVD programme contributed to a sustained focus, sustained to this day, on secondary prevention of CVD across all systems, all 6 systems in the South East, and really aided both the identification of where more intensive action was needed and the development of a compelling narrative to achieve buy-in from system leaders. In the middle column, you'll see that 3 systems are highlighted here as examples of where particularly intensive support was provided and the nature of that support. And of course, then the learning from those projects was shared more widely across the other systems. Sadly, I think there's no time to talk through these individual projects in more detail right now, but I would be very happy to describe these in more detail if you would like to get in contact with me after this meeting. Next slide, please. So moving forward from the 5-year forward view CVD prevention project, as you all know, the long-term plan was published in early 2019 and really cemented CVD prevention's place as a national clinical priority and the single biggest condition where lives can be saved over the next decade. A clear ambition is set in the long-term plan for the NHS to prevent over 150,000 heart attacks, strokes and dementia cases over the next 10 years. And direction is clearly laid out around how partners across sectors and across organisations can work together to achieve that. And the national CVD prevention, secondary prevention ambitions around the 3 high-risk conditions have been taken forward into the long-term plan. Next slide, please. Oh, I think it's going to list the points one by one before moving to the next slide. Thank you. So I'm just going to spend the last couple of minutes focusing on hypertension. With respect to AF, I think it's fair to say that initially our partners and many systems and we particularly focused our attention on AF early on. Progress with respect to AF I think has been good, but the situation with respect to hypertension has not been so good. We've already heard how optimizing hypertension control can have a substantial and relatively rapid positive impact on the risk of cardiovascular events. While the figures shown in this slide are a little on the old side now, I think they still give a clear idea of the scale of events which can be averted through optimal treatment of hypertension in our systems across the southeast. And we can see that there really is an enormous opportunity to prevent consequences further down the line by optimizing hypertension control. Data shows that we aren't doing so well as expected in the southeast. There is wide variation at CCG and system level with respect to the diagnosis and treatment gaps, and we have a very long way to go in the southeast to meet the national ambitions. And sadly, this situation has been exacerbated further by the COVID pandemic, and also with relatively recent changes to BP treatment thresholds, that treatment ambition has become even more challenging to achieve. So the intense focus that we now see on optimising hypertension diagnosis and management in the southeast is entirely justified, both in the southeast and nationally. Next slide, please. So just to summarise our forward journey, the Southeast CVD Prevention Group is still going strong in its support for local and system leadership around CVD. The group continues to play a role in coordinating action and also in linking to other networks and groups in the Southeast. For example, the BAME Mortality Southeast Reduction Board. The CVD data packs continue to evolve to meet local need. There's now a clear focus on the link between cardiovascular disease and its risk factors and the increased risk of poor COVID outcomes and how we can mitigate the inequalities which have been highlighted by the pandemic. And with the models developed in response to the COVID pandemic, there's really valuable learning for CVD prevention. For example, the BP at Home project, which Rory Honey is going to talk about in more detail shortly. Final slide, please. So I've listed here some of the data sources that are relevant to our work around CVD. This is not exhaustive, but hopefully you will find it useful if you want to explore the data further. And please do get in touch if you would like further information about these data sources, about any of the projects that I've touched upon. And thank you for listening.